So now it's my pleasure to introduce you to Prof Luigi Natale. So Luigi is good at a lot of things in radiology. So he leads the whole chest and abdominal section, whole body section at Gemelli Catholic University in Rome. And he's a fellow of every single cardiac society you can think of, from the American to the European one. And he's actually the current president of the European Society of Cardiac Radiology. And he's going to tell you more because the meeting this year is in Rome. So once in Rome,
yeah, the postcard for those who are interested, yeah.
But he's done really great work because on top of that, he directed the emergency center, which included a lot of COVID work, right? And also the acute cardio. So he did a fabulous job in everything sort of ran like a clock, despite the pandemic. And especially, on the acute chest pain. So it's a real pleasure. Thank you very much.
Thank you for the introduction, Aris, and many thanks again to Aris for the invitation, and Fiona, also congratulations for recognition of today. It's my pleasure to be here. A little bit a step back, if I can say, 30 years back when I started my fellowship in London for cardiac imaging in the Brompton. And so for me, it's quite a conclusion of a circle to speak about this problem, these guidelines that it's in my heart because it's a real clinical problem, their application particularly, again in the UK. So thank you very much for the invitation. The topic is, I think, actual because nowadays, since 2011, a lot of studies started, mostly multi-center trial, to assess the capability of non-invasive imaging, anatomical or functional. And there was the need for clinical guidelines that starting from the NICE guidelines in 2016, gave the opportunity to the clinicians to follow a real flowchart. But if we look at the available guidelines and documents nowadays, there are two different, completely different approaches. One of the NICE guidelines is symptoms oriented. Otherwise, on the other end, the European Society of Cardiology, the American Heart and American College of Cardiologists have a different approach that is mostly oriented to the risk stratification. This is a completely different story. And I try to explain this with practical concept during this presentation. So from where we started? It seems a long time ago, many years ago. Where things changed. In fact, if we look at the cornerstone trial, the Scott Hart that you very well know, and it's my pleasure that you are here, this is the first important European randomized trial concerning the outcome. And if we look at outcome, of course, the story is completely different. In the past, all the other studies, randomized or non-randomized trial, were aimed mostly to look at sensitivity, specificity of the techniques, negative predictive value. Here we are speaking about outcome. And this is a completely different approach. And in this study that was published in Lancet, and then there were some other sub-studies, it has been demonstrated that the addition of coronary CTA to the standard of care that includes in this study mostly 12 leads exercise test, ECG, sorry, that the addition of coronary CTA can clarify, in the majority of cases, the diagnosis of angina due to coronary artery disease, reducing the need for further stress testing, allowing a direct address to the invasive coronary angiography if needed, and resulting in a more focused treatment, more patient-oriented treatment with an apparent reduction. In the study, it was not significant at the beginning, at the first evaluation, between patient stratified in the two arms of the study. On the other end, in the States, or better, in Canada and States, there was a different trial, again, an outcome study. This is the second one, published on New England, the PROMISE trial, where the aim was a little bit different. It's always an outcome study trial, but the difference is that there was the comparison between the anatomical testing made by coronary CTA and the functional testing that in this study was mostly done with radionuclide. And in this case, the objective, the primary objective of the study was to compare the outcomes in patients presenting with new symptoms, so low prevalence of coronary artery disease, suggestive of coronary artery disease that required further evaluation. And the randomization was done in these two arms. The primary hypothesis was that the clinical outcome of the patients selected by anatomic testing would be superior to that of the arm with the functional testing. If we look at the results, there were no significant difference in the two approaches. So this seems to deny the usefulness of an anatomical approach compared to a functional approach. But there are some other considerations that we should do. First of all, there are other findings in the PROMISE trial. That is the increased number. It seems to be a negative byproduct of the study, but it's not true, and we will see later. An increased number of invasive coronary angiography in the arm evaluated by the anatomic test, coronary CTA, 1/3, more or less, more. Also an increased number of revascularization. And of course, there was the problem of the exposure, the radiation exposure. Why? Because in this study, the percentage of stress echo was not significant and stress CMR was not included. I told you that it seems a negative result to increase the number of invasive coronary angiography, increased number of revascularization, but it's a false in negative result, because in these two categories of patients, we increased also the survival rate of these patients. So it seems to demonstrate a better rate of selection of the patients to revascularization. If we compare these two outcome studies, we can see there are some differences that also explain the differences in the results, because mostly you can see that apart from the number of the patients enrolled, all the patients in the Scott art were symptomatic, chest pain in 100%, and 3 out of 4 had chest pain in the other study. So there is a number of patients without chest pain in the PROMISE study, and this makes a lot of difference, of course. There is also a percentage of patients with previous coronary artery disease in the Scott art and no in the PROMISE. What is important to underline these factors? First of all, because the prevalence of the disease is different. And second, because it reflects the healthcare orientation of the two different approaches. Scott art, it means symptoms-oriented selection of the patients. PROMISE, or PROMISE, I don't know exactly how to say, reflects the approach of the risk stratification. Okay, so a big difference, of course. In a sub-study of the Scott art, published a little bit later, a big result was obtained, because if you remember the first graph of the first Kaplan-Meier curve, there were no significant difference. The hazard ratio was low between the two arms. But if we look at the 50 days after the enrollment of the patients, meaning the time accounting for the knowledge and the results and the decision-making for the treatment and also the starting of the medical treatment, we can see that there is an halving of the events in the arm of coronary CTA. So this is the true result of the Scott Hart and not the first one, where there was no difference between the two arms. Okay, and this is different according to the prevalence of the disease and the kind of enrollment if we of the Scott Hart compared to the PROMISE study. And then after these two cornerstone outcome studies, we had nice guidelines. And as I remark again, these kind of guidelines reflect a symptoms-focused approaches. I don't want to bore you reading all the differences between 2010 and 2016, but what is important is that if we are dealing with a patient that after clinical assessment as an untypical or atypical angina, we should offer him coronary CTA. This is the first statement. And the second one is that if the chest pain seems to be non-anginal, but the ECG, the 12-lead ECG is abnormal, we have to offer him again a coronary CTA. This is these are the two main points, key points of the NICE guidelines. This kind of approach is also cost-effective. In this study, performed looking at the cost-effectiveness of different approaches, we can see that with the light brown dot and also the light blue dot, we can see that the line that join these two dots, meaning coronary CTA and basic coronary angiography, all the other tests are below this line. So they are less effective and or less with higher costs. So this is the best kind of approach in terms of cost effectiveness. I offer the patient the coronary CTA, and if needed, I go to invasive coronary angiography. So we just mentioned the two cornerstone outcome trials and the symptom-oriented approach. That is the NICE guidelines. Let's look what the cardiology societies offer. A completely different approach that is oriented based only on the pre-test probability of disease, of coronary artery disease to be present. These guidelines published in 2019 have been revised to focus on chronic coronary syndromes instead of stable coronary angiography, stable coronary artery disease. This was the previous edition of the guidelines. Why? Because the concept that there is a continuum in the atherosclerotic process and also in the functional abnormalities of the vessel wall between the acute and chronic is just a continuum in which we can offer the patient changes in terms of lifestyle, different pharmacological strategies or revascularization, but it is the same disease. So what is different is not stable coronary artery disease, but it's acute or chronic presentation. That's the main goal of the revision of the guidelines. And in fact, in 2019, we had the chronic coronary syndromes, and in 2020, the acute coronary syndromes guidelines. What is important to underline in these guidelines? Again, I don't want to bore you with this list, but the main message is that you remember that in the European Society of Cardiology guidelines, class 1 is a first-line indication. And then you have to add a letter according to the level of evidence, A, B, C, with high level for A, derived from randomized trial, and lower degrees of evidence for B or C. So in class 1, we have the most important indication as the non-invasive functional analysis imaging for ischemia, so stress testing, or coronary CTA are recommended as the initial test for diagnosing coronary artery disease in patients with symptoms with chest pain, in whom obstructive coronary artery disease cannot be excluded by the clinical assessment alone. So the vast majority, the large majority of patients that present to the cardiologist or to the clinician, generally speaking. Of course, the test is also indicated, ischemia testing or coronary CTA, based on the clinical likelihood, and that's what I told you at the beginning of the analysis of these guidelines, the clinical likelihood of coronary artery disease to be present. And of course, if we have a result in which coronary CTA is debatable, the result is debatable, functional testing is recommended. So these are the three most important messages. We just can focus according to the NICE guidelines on one end, and this kind of approach based on the clinical likelihood of the coronary disease presence, that we are facing with a very rapid increase of demand of these tests. And this is one thing that we should take into account very, very carefully. In these guidelines, there is a step-by-step approach to the patient, and you can see at step 5 that the diagnostic testing is a balance between the coronary CTA as non-invasive or ischemia test as non-invasive on the other end, according to the pre-test likelihood. The authors underline that based on the evidence, coronary CTA should be preferred if the pre-test probability is lower, and ischemia testing should be preferred if it's a little bit higher, maintaining the concept that without risk, of course, we should not offer anything, and for the very high risk, we should go directly for the invasive coronary angiography with invasive functional evaluation, FFR or whatever. But of course, there is not only the probability, because this is something that can be debatable if I had to go for low risk with coronary CTA or intermediate to high risk with stress testing. What is really evident, what is really evident is, as we will see later, is the local expertise and the local availability of the technology. In other words, if I have a wonderful nuclear medicine in my hospital and a poor CT technology, there is no matter about this, there is no discussion about the test that I should offer to the patient. This is something that we should take into account when we go for the decision making. As I told you before, in 1 year later, also the acute coronary syndromes guidelines were presented. And once again, without reading everything, look at the last lines. CTA is recommended as an alternative invasive coronary angiography to exclude acute coronary syndrome when there is a low to intermediate pretest probability of coronary artery disease, and cardiac troponins and or ECG are normal or inconclusive. This is something that is particularly important because it reflects two things, in my opinion. First of all, a different management of the patients in the emergency department. And second, in the COVID period, the huge number of patients that presented in the emergency department with chest pain and a mild rise of troponins, where these kind of values were inconclusive. At the beginning, I remember that, for example, in my hospital, but also in other, there was a huge increase of invasive coronary angiography in these patients. And it was not well seen by cardiologists, of course, because of the COVID situation. After 6 months in my experience, we started to offer in this kind of presentation, very specific coronary CTA, adding late enhancement in CT. And we selected a lot of myocarditis. So it's a double-faced story. On one end, we can base on the high negative predictive value of the test because we are dealing with patients with low to intermediate. That is the best setting for the test for coronary CTA. On the other hand, we can add a diagnosis of myocarditis using late enhancement in CT. Of course, we are speaking about guidelines. We spoke at the beginning about randomized trial. If we refer to the level of evidence of the guidelines, I told you A is randomized trial, B is non-randomized trial or large multicenter trial, and C generally is expert consensus. But we cannot skip expert consensus at all, even if they put the level of evidence in a lower, in the lowest class. It's important because usually when we put together all the big experts of a topic, we can learn a lot. And in 2021, this document by the Society of Cardiovascular CT was published and summarized, more or less, put together the indication for coronary CTA, merging the NICE guidelines and the European and American Heart Association guidelines. So it's something that is particularly useful in clinical practice because it put together the symptoms-focused approach and the risk stratification approach. And coronary CTA is definitely as appropriate. There is a score between 7 and 9 that is joined by consensus by the experts of the document. In this situation, as first-line examination, known or unknown coronary artery disease and typical angina or equivalent of chest pain, whatever. So a very, very big number of patients. Second, prior, and this is in my hospital, for example, there is an explosion of this indication for non-coronary cardiac surgery in, valvular patients, for example, in low to intermediate risk patients, younger with non-degenerative valvular conditions. Nowadays, all patients that are candidates for surgery, or of course for TAVI or for mitral replacement or whatever, undergo a coronary CTA. Of course, based on the capability to exclude coronary artery disease, the high negative predictive value, also in the differentiation between ischemic and non-ischemic dilated cardiomyopathy, it's a good test. In my opinion, CMR is better. But if we want to look at the anatomy and we are able to exclude not stenosis, but atherosclerosis, it's an efficient test. And of course, it is useful also when we are dealing with a non-conclusive functional test. For example, a big category of patients, women, mid-age, with inferior perfusion defects at nuclear tests. There are a lot of false positives, and CT is a very good indication in this case, instead of invasive coronary angiography. And of course, is appropriate in graft patency evaluation, graft, not stent. So, of course, coronary anomalies, it's a very, very good indication. All the things that I mentioned in these two different approaches of the guidelines, symptoms or risk stratification, have the same conclusion: a huge increase of the demand of this examination, particularly coronary CTA. I think you well know this study that was conducted in the UK, where, just to summarize, there is a huge increase of the number that should provide it very rapidly in the next year, from 40,000 to 35,000 per year. Or if you look at the number of patients, or for the population, yes, for 100,000 patients, there is an increase of quite tenfold. So it's something that we are not prepared to deal with. And the same results of these studies, there is one of the studies that was conducted in UK, but there are also others that confirm this data, derive also from the survey that we conducted last year as a European Society, in which we saw that in red you can see also only the European countries that answered the survey. All these patients are not, all these countries are not ready to offer this kind of demand. What is the limitation? First of all, is the number of scanners. Second is the slots per scanner, because we are dealing with many other studies. First of all, oncology, for example. But the availability of technology is not the only limitation. We have also to think about very, very deeply to the education and training. And these three points are not easy to be solved in the same time in which we will see the increase of the demand of these tests. So it's a really, really big problem. Okay, let's move to the function. That is something that I prefer. In 2021, so last year, these guidelines about chest pain, it seems symptom-oriented, but it's not, because it's, again, based on the pre-test probability. Some new definitions were given by the American societies. First of all, it is a biggest assumption. Chest pain was considered an angina equivalent if presenting as pain, pressure, tightness, discomfort in chest, shoulder, arm, neck, back. So a very big number of districts, and also a large number of situations in which the cause is not angina, to be honest. Shortness of breath or fatigue, it's much more difficult to consider only cardiac causes. But if we consider an angina equivalent, each of these situations, of course, again, we will deal with a lot of number of tests that are required. Second, as the step-by-step approach that we saw on the European Society of Cardiology guidelines is also present here, from the initial evaluation, acute or chronic or whatever, lab test and so on. Look at the red lines, patients with acute or stable chest pain at intermediate or intermediate to high. So we are moving higher compared to the European Society guidelines. Risk of obstructive coronary artery disease will benefit the most from cardiac imaging and testing. We are putting together anatomy and function here, and we will see later what is the difference suggested by the guidelines. And finally, the clinical decision pathways for chest pain in the emergency department and outpatient settings should be used routinely. This is a strong recommendation. And to be honest, according to what is my experience in Europe and in the past in the States it's much more easy to go to work according to the guidelines. In Europe, it's a little bit different, particularly in my country. This is the central picture of the document. You can see here what is the big difference comparing to the European guidelines. You can see here that in patients with chronic chest pain and low risk, there is indication to do nothing, no testing. at least we can use optional testing, such as stress ECG or coronary calcium scoring. But this is a strong difference. For the intermediate and high risk patients, different approaches are considered: anatomic or fractional testing, or directly for the high risk, that is the right choice, in my opinion, the invasive coronary approach. Of course, if a patient is presenting in the emergency department with symptoms clearly referable to an acute coronary syndrome and high sensitivity troponins increase, whatever, we should go directly to cath lab because, as you know, time is muscle, as cardiologist says. So the problem is, what are we going to, how we can do a choice between anatomical testing, coronary CTA, or functional testing that is in this document mostly perfusion CMR, stress CMR. And once again, there is not a definite choice. What is really important is the local availability and expertise. Some differences are considered. For example, younger than 65 or older than 65. In younger patients, there is a favor for coronary CTA. For higher than 65 for stress imaging, but these are not the key in the decision making. The key in the decision making is how is the opportunity to have a definite result from a test in your hospital. If you have, again, a strong, in this case, MR lab, able to do a lot of perfusion scans, maybe it's better. If you have a poor or not a state-of-the-art technology for a coronary CTA. Just to remember, the basis for a coronary CTA nowadays is a 64 scanner. Lower than 64, forget it. But probably in the near future, also 64 will be not enough. Let's think about to old patients that have rhythm problems and how easy it is nowadays to obtain good results from patients, for example, with atrial fibrillation, with a scanner at the state of art, whatever is the availability, to tubes or a large panel, doesn't matter. But with the new technologies, also difficult patients can give good results of your test. So technology is the key. And the second key is, of course, the local expertise. What is the evidence for the perfusion stress CMR? Here you have some important or landmark randomized trial, and the last two are not randomized, but also there is a strong evidence from these studies. Very rapidly, this is the first and the landmark study for perfusion CMR that we compare to Scott Hart for CT. Is the MR impact. It's an old study with an old technology, but when it was published, it was able already with a high disease prevalence to demonstrate that CMR was not in the continuous black line, is not inferior. So it's a non-inferiority trial. It's not inferior in all vessel disease or multi-vessel disease only, compared to SPECT imaging. So if I have a non-inferior test that is completely non-invasive, why not to go for perfusion CMR? This is the conclusion of the study. This study was repeated a few years later. And in this case, with a better technology, it was possible to demonstrate, if you look at the AUC values, that CMR is superior to SPECT imaging in all patients or in only multi-vessel patients. And let's remember that multi-vessel disease is a limitation for SPECT imaging. In the same year, another multicenter trial was published. It's again a UK-driven study with a lower disease prevalence. This is very, very important. And whatever is the gold standard for the assessment of the relevance of the significance of the stenosis, so using different cutoffs for the main trunk and or the same cutoff for the main trunk and the three vessels, the CMR, perfusion stress and CMR, this is the blue line, performed better in all the situations compared to SPECT imaging. So again, a superiority demonstration of the technique. But what was very, very important is that this difference is particularly evident in females. I told you that if you look at the females that are the graphs on the right, the difference is pretty high between the two techniques because of the large number of false positive tests that I mentioned to you before in females of SPECT. While for men, for males, sorry, there are no differences. So we have a very robust test, particularly in a class of patients, females at middle age, in which the reference standard, particularly in the USA, that is the nuclear scintigraphy, fails in a large percentage of patients. This study, CMR, was repeated again, a little bit different and in a more modern fashion, because this study had a primary endpoint to demonstrate the perfusion CMR superiority, not compared to SPECT imaging, but to the NICE guidelines, direct care of the patients. And also SPECT was considered as a third arm for the functional test. And what we see here is that in patients with suspected angina, investigation by perfusion CMR resulted in a lower probability of unnecessary coronary angiography within the year compared to the NICE guidelines results. I just want to remember you that NICE guidelines say you, let's go for coronary CTA as first test without significant differentiation in terms of pretest probability. This means that, sorry,
not to interrupt the curriculum, but in this trial, the NICE guidelines were the preceding NICE guidelines, which is why they had such a high rate of invasive angiography.
Yes, I would like to comment this point at the end. Sure, not last guidelines, but the 2010. You're fully right, but it was my final comment for you.
Sorry.
Don't worry, absolutely. With the previous approach, the number of patients with high calcium scoring, I mean, mostly, needs to be investigated by invasive coronary angiography in all the situations. Why? Because you know that high calcium scoring is a risk stratifier. So it's able to put a patient in a low to intermediate risk class, for example, in a high, or a patient that was considering the clinical factors in the high class, down classified in an intermediate or low risk. So it's very difficult to correlate according to the presence of higher or lower number of calcium scoring, the possibility to have a significant stenosis, a flow-limiting stenosis. That's why, in this way, we can increase the number of invasive coronary angiography. Of course, we are dealing again with anatomy. This is a little bit different compared to coronary CT angiography, but it's anyway, calcification is just an anatomic landmark, okay? So in this way, we saw that patients with CMR approach or SPECT approach, without significant difference between the two groups, reduce the number of unnecessary coronary angiography. What is very, very interesting should be to repeat this study, comparing the new NICE guidelines with a state-of-art perfusion CMR. But at the moment, to the best of my knowledge, this kind of study is not on the go. There are some similar studies, but not perfectly suitable compared with this approach. That was particularly interesting in my opinion. Another important study was published later. This is the MR-Inform. It was an unblinded international multicenter prospective clinical effective trial in which the management of the patient was guided in two arms. One is the invasive FFR measurement of the fractional flow reserve with coronary angiography plus optimal medical therapy, and the other arm, stress guided plus, of course, optimal medical therapy. And the primary endpoint were major adverse cardiac events. And what we saw, and also a cost analysis of this kind of approach was done. And what we saw in the two groups is that looking at the patients in the arm guided by FFR, a larger number of revascularization was present compared to the ischemia testing, the CMR ischemia testing. That is more or less, I see, quite 20% more. If we look at the results of this study after more than 1 year, substantially follow-up, we can see that there were no differences in major adverse cardiac events between the two arms, and the hazard ratio demonstrated a non-inferiority of the ischemia testing approach compared to what is considered the gold standard. Why I'm saying considered the gold standard? Because FFR reflects only epicardial vessel disease. One mistake that is frequently done by my residents, for example, is to make a confusion between fractional flow reserve and coronary flow reserve. They are completely different. Fractional flow reserve is a surrogate of the significance of the stenosis, the flow reduction, obtained by the measurement of the drop of the pressure below the stenosis. Coronary flow reserve is another story, and coronary flow reserve reflects also microvascular damage. All the functional types of angina are included. You can have a situation in which FFR is normal and coronary flow reserve is abnormal, is reduced. And it has been demonstrated first in the animals and then in the humans by means of PET-CT, perfusion, perfusion PET imaging. So this has to be clarified because the non-inferiority of these results are something that could be debatable, because we have to see what is the prevalence of coronary artery disease in the population we enroll, and also if there is the presence of a functional angina and microvascular damage or microvascular angina, functional angina as you want to call it. Finally, two different studies, not randomized trial, so lower class of evidence, but very important. This is a registry, the SPINS registry, that is particularly interesting because it's conducted in the States with a big number of obese patients, also Black population with different prevalence of coronary artery disease. 13 centers in the USA with a very long follow-up. Median follow-up was more than 5 years. And what has been demonstrated is that in patients with stable coronary artery disease and intermediate risk, the stress CMR without evidence of ischemia and without evidence of late enhancement had a better prognosis. Why I say late enhancement also? First, because speaking about technique, we have also to take into account when we perform a stress test, we have always to do lead enhancement. Because it's for free, first of all, and then we know from previous studies that more than 10% of patients with coronary artery disease have an unrecognized myocardial infarction. And this is a very bad prognosticator. So the knowledge of the presence of a silent previous myocardial infarction is a strong factor that can modify the prognosis of the patient. So the best prognosis is for patients without ischemia and without previous myocardial infarction. And this is clearly demonstrated by this registry. And final, this is a cohort study, also multi-center, with a significant number of patients, and again, a long follow-up, more than 5 years. In patients without history of coronary artery disease, this is important. And you can see here that, again, patients with no latent onset and no ischemia, no inducible ischemia, this is the blue line, had a better prognosis, both for cardiovascular death or non-fatal MI, or in general, comparing all cardiovascular events comprehensive of stroke. And this is true for low risk and intermediate risk. And this is the particular value, in my opinion, of this study, that the survival rates are differentiated between low and intermediate risk patients. So again, a strong demonstration of how perfusion CMR is effective. And the second added value of this study is the modification of the management of the patient according to the result of perfusion study. If you see in the first part of the figure with A, this is the pre-test risk of cardiovascular death and non-fatal MI according to the common clinical risk stratification. And you can see here how the post-test risk according to the results of perfusion CMR changes. So this reflects modification also in the treatment of the patients and all the other medical choices that can be done after the test. This is a final comment about all the tests that are available nowadays. A document published by the European Association of Cardiovascular Imaging Society. It is a cardiological society in which are included all the people, all the cardiologists involved in imaging, CT, echo, nuclear, MR. And there is a very interesting differentiation. It's the capability to rule in or rule out coronary artery disease according to the pre-test likelihood of disease, but with two different standards of reference. On the right, on the left, you can see the significance of the stenosis, so the percentage of the stenosis. You know that over 50% we consider significant stenosis and define it according to the classification of the Society of Cardiovascular CT as mild, between over 70 up to 90 intermediate, and then severe. So if we put the cutoff of the significance of stenosis at 50% as the central dot line, you can see that the best test able to rule out the disease, that is the figure on the left and the green bars, CT is the best test. But if we look at the significance of a stenosis invasively measured by FFR during invasive coronary angiography, things are a little bit different. Why? Because we know since years 70 of the last century that anatomy does not reflect function. So we know that when we go for the assessment of the reduction of the fractional flow reserve, the best tests are the functional tests, particularly perfusion CMR and PET, perfusion PET, of course. So it's always important to take into account what we are looking for when we use a test. Just because I told you at the half of this presentation that I am in favor of CMR because I am a CMR guy, to be honest, I would like to summarize in this table what are the indications in class 1 for perfusion CMR. Why? Because until this document, CMR was never included in guidelines. When they spoke about functional tests, the reference was always to stress echo and stress SPECT mostly, or stress PET in few cases. Stress CMR was licensed in this document for the first time. And you can see that there are a lot of indication in class 1. Of course, for acute presentation, and the functional test can be considered in patient without non-coronary artery disease, for example, or in patient with non-coronary artery disease and presence of coronary artery bypass. If you want to see in patients with acute chest pain, if there is a problem in the bypass graft, you can go for CTA, or for, that is more easy, to be honest, or with perfusion CMR. But more important is in the stable setting, in the chronic setting. So, sorry, it's better to, even if the American societies prefer to maintain acute and stable, we can go with the European classification. It is more suitable for the clinical application with acute and chronic. And in patients with unknown coronary artery disease with intermediate test probability to have significant coronary artery disease, perfusion CMR is an excellent choice, as well for in patients with obstructive coronary artery disease, for example, non-interpretable CT. Let's think about all the patients with a large amount of calcium, for example. So these are my last consideration in favor of a wide use of perfusion CMR. In non-invasive imaging, it's not only coronary CTA, even if it's more easy to be used. But in my opinion, there is a large possibility to use CMR, perfusion CMR also. And for those who are interested, let me do a spot for our Congress, European Society of Cardiovascular Radiology. This year will go finally after 3 years in person. We will have the Congress in Rome for the conclusion of my term of president. And I would like to invite you, here are the postcards for those who are interested. Thank you very much for your attention. Of course,